Hi, I'm Joel Gernsheimer. I'm one of the attendings in emergency medicine, and we're going to talk on geriatric trauma. Okay, so what are our goals and objectives here? We're going to learn how to evaluate trauma in the elderly, how to manage trauma in the elderly. We're going to talk about us old geezers versus you young people as far as trauma goes, and talk about some special considerations and pearls and pitfalls when evaluating and managing trauma in the elderly. So why are we going to do that? Right? What are some pathophysiology and principles that we should follow? How do you do a good evaluation in an older person, particularly ones who have fallen? How do you manage them? And some special injuries and considerations. So why? So there's a thing called the silver tsunami. The world, and especially the US, is getting older and more silver-haired, like me. Why I have none hair left. So you got to be prepared for it so it doesn't swamp us, right? So we're all getting older, including Silverberg. Eat your heart out, Silverberg. Okay. Right. And it's so important that our first chairman, Tom Scalia, who's the head of shock trauma in Maryland, actually had a two-part series that involved mostly the trauma in the elderly. So why, again, is it important? So it's the fifth leading cause of death in people over 65 years of old. More morbidity and mortality. But if you do the proper management, you're aggressive in both evaluating and in treating severe injuries, they do well. So why do older people get injured? Number one by far is falls, and it's falling from a height. Just recently, a couple of weeks ago, my sister-in-law, who's 92 years old, has dementia, but she enjoys looking out the window. She turned around from looking out the window, fell, landed on her back, broke two vertebrae, and then now is in physical rehab. Right? MVAs, collisions, pedestrian struck. People like me and Silverberg have trouble walking across the street, and we may get struck more easily, and we break more easily. Suicide can occur, especially get depressed and about getting older and stuff, or especially if you don't have a good support system. Burns, older people with burns are much more likely to have bad morbidity and especially mortality, particularly, for example, in a mass disaster with older people getting burned. An older person with a lot of burn surface area may be someone that you don't try to resuscitate ahead of others because the prognosis is so bad. Assaults, abuse, and something you always have to think about when injuries don't make sense, just like in young people, when little kids, when the injuries don't make sense. The same happens in older people, particularly ones who can't defend themselves because they have dementia or chronic illnesses. And penetrating trauma is less common in older people, but it does occur. So falls is a geriatric syndrome. Again, fall just from your own height is the number one cause of significant trauma. And myself and Sonia Patel, just a week ago, we had two older patients who had significant fractures. One of them just twisting, getting out of a wheelchair, and the other one just going to daycare seemed to break his ankle. So you have to be very suspicious. And it affects everybody. It'll affect you in the ED. It'll affect the patient, obviously. It'll affect their family. And it affects society as a whole. So one of the things you have to worry about when you have a patient who fell is to ask yourself, why did they fall? Number one, you want to rule out an acute life-threatening problem. Like maybe they had a dysrhythmia. Maybe they had a stroke. Right? So you want to really do a good evaluation to make sure they didn't have some medical emergency that caused them to fall. And the second most common is chronic medical problems. For example, they have a vision problem and they fell because of that, or they have a weakness in one side of their body and they fell because of that. And older people who fell before, the biggest risk of falling again is you already fell once. Medications are very important. And when you prescribe medications to older people, you have to worry about it. It'll may help cause them to fall. There was a recent article in the New York Times that talked about the increasing falls in older people. And one of the studies that they quoted was because of medications. Things like benzodiazepines, things like too much antihypertensives that gave postural hypotension. Alcohol, right? We don't think of us older people as drinking, but me and Silverberg, we often go out and drink together, right, Mark? Okay. And then the home environment. So sometimes you send home a patient who fell and you're worried about them. You can get visiting nurse service to go in and to look at the home, make sure there are no rugs that are causing them to fall, make sure. One patient that I had, it turned out she had 10 dogs and 10 cats in her house, and she was falling because she kept tripping over her dogs and cats. True story. Okay, so why are these particular mechanisms of injuries important to the elderly? So a one-person motor vehicle collision, they may have had a major medical problem that caused them now suddenly to have an accident. For example, one of my colleagues years ago at Lincoln, older guy, good doc, though, good emergency doc, he's coming home from the Bronx to Queens, and suddenly his car crashed into one of the barriers on the Triborough Bridge, and it turned out he had had a stroke that made him slowly crash into this barrier. He wound up actually dying. Pedestrian struck, very common. Right? Queens Boulevard. I don't know if any of you have tried to ever cross Queens Boulevard. Right? I almost got hit there a few times trying to cross Queens Boulevard. Right? Because you walk slow and the cars go fast and the light changes too fast. Large burns, very bad prognosis in the elderly. And then repeated falls are important because, again, one of the biggest risks for older patients to fall is if you fell before. And so you have to investigate why they fell the first time. And we always use that term mechanical fall, like, oh, they just tripped. But you have to be careful that there's something why they tripped and they may fall again. Right? So you always want to think about preventing refalls in both the ED and at home. As Benjamin Franklin said, sometimes an ounce of prevention is worth a pound of cure. So if you have someone you're worried about their home situation, you're worried about their follow-up, an older patient, get care management involved. And they can get home visits. They can arrange for rehab. They can arrange for someone to look at their medications. So what are some modifiable risk factors that you can look at and change so they don't fall again? So looking at their balance, their gait, muscle strength, any neurological problems, especially medication use, sensory impairment like vision, anything in their environment. And then again, if they fell once, they're at risk to fall again. And here are some tips maybe to prevent them from falling again. So there's a study in the Annals of Emergency Medicine that said some things that can be done in an ED that can prevent future falls are one, physical therapy, or at least getting them things like walkers and wheelchairs, and then a pharmacist's intervention in the ED to look at their medications. And in fact, one of the reasons why we're able to get a pharmacist in the ED on both sides of the street, right, Francesca and Sonny, was because we were applying for geriatric ED accreditation, and we pushed to have an ED pharmacist to help with older people, particularly older people who fell. And in this study, having physical therapy, or at least things to help with walking in the elderly and pharmacist intervention, the ED, decreased 6-month ED return rate. So why are older people, again, more likely to fall? Well, as you get older, you get a decline in your physiological systems, right? You lose your reserve. Plus, you get exposed to more and more diseases and toxins. So you're more likely to have increased morbidities, increased comorbidities. And these are systems that as you get older, start to get impaired and can lead to why you may fall, or if you do fall, why you may not recover so easily. So what are the consequences of all these changes that you see in the elderly? And not just because it's more, bless you, because of more risk of falling, but for any kind of disease. So the consequences are us elder people are more likely to have more diseases, right? I myself have hypertension, diabetes, high cholesterol, normal ejection fraction, CHF. I have two fake hips. I have half a fake back, right? So you're more likely to have more diseases. Presentations are more complicated because of these comorbidities. We're less able to cope. So if we get an illness, we go downhill much quicker. And usually our diseases have greater severity. And we're also more likely to have adverse drug reactions because of decreased metabolism and excretion of drugs. So my important 4 GEMs, my geriatric emergency medicine principles are comorbidities make diagnosis and treatment difficult, both in trauma, but also in other medical emergencies. Diseases often present atypically, make the diagnosis more difficult. And older patients are more likely to decompensate rapidly, both from trauma and from medical causes. And there's an increased risk of adverse drug reactions. So geriatric trauma, morbidity and mortality are greater. Triage, evaluation, and treatment are more complicated. And significant injuries in an older person probably needs a trauma center if you can get him there expeditiously more than a younger person with the same injury. So I'm going to start with the primary survey and resuscitation. Similar, it's always A, B, C, D. However, it's a little bit different. So you're going to have your airway with C-spine control and with resuscitation as needed, your breathing, your circulation with control of hemorrhage, your disability, and then your exposure environment, and then a great exam, right? Head to toe, front and back, maybe fingers and tubes in every orifice. But here are my elderly ABCs. So remember, diseases can be atypical. You have to be very aware of possibility of really life-threatening illnesses that may present atypically. You have to pay a lot of attention to these patients. You always have to be nice. You have to be compassionate and caring. And you have to be supportive and think about the social issues, particularly when you discharge them. Okay, so the elderly airway, you want to avoid hypoxia, give as much oxygen as you need to give. Bagging may be difficult. So if they have dentures, when you bag, you take the dentures out initially? No, you leave them in. When you intubate, you take them out. Unless, again, you can't get a good seal with the dentures in. Right? Intubation, you may need to do earlier and it may be more difficult. More likely that they have a C-spine injury. And you may have to adjust the rapid sequence intubation doses, right? Because the older people are more likely to be sensitive to them. They're more likely to have trouble with renal excretion, etc. Breathing, you want to make sure they don't get hypoxic. You want to worry about chest wall injuries because they're more likely to get pulmonary contusions. They're more likely to get respiratory failure. But don't forget to give them pain meds and good respiratory care. And a lot of times we don't A lot of older people don't complain as much as you young people, but we deserve pain medication as well. In fact, when I had my hip replaced, I loved my morphine. Too much, probably. As far as circulation goes, there's decreased cardiac reserve. But on the other hand, older people don't respond well to hypovolemia. And the clinical evaluation may be misleading. Why? What are some things you can think of may be misleading? They're less likely to show what? That younger people might when they become hypovolemic. They're less likely to be tachycardic. They may be on beta blockers. They may be on some calcium channel blockers like tildiazem or verapamil that may block the heart rate from becoming tachycardic. They may have intrinsic heart blocks. So the tachycardia just may not be there. And meds that they're on may mask or worsen hypovolemia, like if they're on diuretics. And you got to really closely monitor them and look for bleeding, especially for hidden bleeding. Right? So where are the places you have to look for hidden bleeding in elderly trauma victims? Again, the abdomen, number one, chest, retroperitoneally, pelvis, and the hip and long bones. So as far as circulation goes, you want to be aggressive with your fluid resuscitation and your transfusion. On the other hand, you have to watch them really carefully so you don't fluid overload them because they may have underlying CHF. So it's, it's a very precarious kind of walk. Again, look for hidden bleeding, and you want to be aggressive with your imaging, maybe more so than in younger people who can give you a better history and who have more physical findings. Consult surgery and, if need be, radiology early on. And one thing you have to worry about, particularly with head trauma, is reversing anticoagulation, because a lot of older people are on things like Eliquis and Coumadin, etc. And if you don't reverse their anticoagulation, they may bleed and bleed and bleed, especially in their head. Disability, it's important to find out what their baseline is, if they have an underlying dementia. Their brain is at greater risk for injury, and even minor injuries can cause subdurals. The spine's at greater risk, and they're more likely to have spinal fractures. You want to be liberal about your use of the CT. Especially, there's a recent study in academic emergency medicine that looked at when you should see older people who hit their heads. And the conclusion was you can't really always follow your clinical judgment. So if there's any question at all, you should get that CT to look for bleeding. And if you're going to get the CT to look for bleeding, you probably should get that CT to look at their C-spine at the same time. And just a couple of weeks ago, my sister-in-law, who's 92 years old, who has dementia, she was looking out the window. She turned around, slipped, fell on her back, and broke 2 vertebrae with minor trauma, just falling on her back, and now is in rehab. So you want to, again, be very careful and be aggressive about imaging. And again, watch out for anticoagulants. So these are pictures of subdurals, and all of them are from cases that weren't from great trauma, right? This is an acute subdural. This is a what? Subacute. And you may miss this because the color is similar, although you can see that shift, right? And always when you look at CTs or X-rays, you want to always think about GLG, right? God loves Gernsheimer. He made things symmetrical. So if they're not symmetrical like these, you got to worry there's something bad there, right? And he has a chronic subdural. This patient, or a very similar patient, I saw in UHB about 10, 15 years ago, who Wife brought him in because he was complaining of a little headache. And he had just had a minor falling from his kitchen chair about a week before. And I didn't find anything much neurologically, except his wife said he just seemed different. He had underlying dementia, but she knew him well, and he seemed different. So I got a CT, and his CT looked just like this. And so alert, but was complaining of this headache and just wasn't himself. Wound up going to MIMO to get surgery for this. So you want to be very careful. C-spine fractures, again, usually you'll start with a CAT scan. And again, you may miss those. They may not have you may not be able to follow those rules, the Canadian spine rules, et cetera. If you're suspicious at all, get the CT, at least to start with. And spinal fractures are common, and neurological deficit like a central cord syndrome are very common. So what is a central cord syndrome? Most likely you're going to see it in old people. What is the risk, the mechanism of injury, and what do you find on your neural exam that would make you suspicious of this? Anybody? Anybody have seen this? At least seen it on the boards if you haven't seen it in real life. They love to put it on the board. Right? So this is kind of like guy's driving his car. He gets whiplashed, an older person, and now they have weakness worse than where? Worse in the upper extremities than their lower extremities, right? That's the clue. Kind of this whiplash kind of injury, and then weakness in the upper than lower. And mostly you're going to see this in older people, and you don't want to miss this. Right? Then you're going to undress patients. You don't want to let us older people get too cold. We don't do well in the cold. I have right now 2 undershirts on. And you want to monitor them closely because they don't do well if they become hypothermic. Your secondary survey, you want to do an ample history, allergies, medication, past medical history, last meal, and the event, a good history of what happened to them. And you want to really do a good physical exam, and the injuries may be subtle. And you want to be very liberal again, getting imaging. It's just as me and Sonia Patel, boy, I didn't think those patients had fractures. One had a bad femur fracture, the other had an ankle fracture. And if you're going to give them medication, you want to do the SLGS. What does that stand for, SLGS? No. That we like. We'll talk about that later, me and you, in private. But no. It's start low and go slow. So you may want to start with a lower dose than you normally would give if you're giving things like morphine or Dilaudid, if you're giving that at all to older people, right? And then you can always increase it. So start low, go slow. But thank you. Made my day, right? And then you want to do definitive treatment. And always you want to think about risk benefit, particularly in older people, right? You have someone who has bad dementia. How much are they going to benefit from this invasive treatment or not? What is this an ultrasound of? Right? There's blood there in the belly. Okay, and then some special injuries, right? Chest wall, rib fractures are much more common. Pulmonary contusions are common. So if they have significant rib injuries, probably need to keep them to observe them because they may go into respiratory failure, more likely than younger people. Abdominal injuries, again, you have to have a high level of suspicion. The clinical exam may be misleading. You're not so likely to find things like incredible guarding and incredible rebound, right? So just, hey, it hurt in the right upper quadrant. They didn't grimace when I touched the left upper quadrant. That's enough for me to do a CT on an older person who is involved in an injury and hit their lower chest or their abdomen, right? You need to always monitor and reevaluate. If you're going to send home somebody who's been involved in trauma, particularly an older patient, re-examine them, see how they're doing before you send them home. And again, you want to image aggressively if you have any suspicion they may have a serious injury or a risk for a serious injury. Musculoskeletal injuries, very common, and they lead to the deterioration of their activities of daily living and eventually to their life, both the quality and even the quantity of their life, right? Common fractures are wrist, the hip, the femur, the humerus, and the pelvis. And you want to do a good exam, especially with neurovascular exam, and you want to do appropriate imaging. What's the most common fracture in older people who fall? Anybody know? It's a Colles fracture. And even though that doesn't seem like a big thing, it may not heal well in older people unless they get good treatment, right? Hip fractures are very common, and the hip x-rays may not show a fracture. When I had my hip fracture, that led to me now having 2 fake hips. I was just walking home one day, 1 a.m. in the morning, coming from a shift at Kings County, and I suddenly felt pain in my hip. And I got an x-ray, just showed some DJD. Okay, no big deal. Got worse and worse and worse. I was working on it for almost 2 months. Finally got to the point where I couldn't get into a shift on time, and I was afraid that Silverberg would yell at me. And so I got an MRI, and it showed a fracture, and I wound up being on non-weight bearing for 2 months and eventually had to have my hip replaced. And I walked on it so much that I deteriorated my other hip, and I finally had to have that replaced. Okay, and here, right, and here's an x-ray that didn't show a fracture. And so if you have someone in the ED, an older person who fell, you're worried about a hip fracture, x-rays are negative, I would get a CT. And if that's negative and I'm still suspicious, they can't bear weight, I'd arrange for an MRI. And if they have things like a femur fracture, like we had somebody last Friday, me and Sonia Patel, you want to get ortho involved and you want to fix it so they can walk again. So older people, if they stay in bed, they get pneumonias, they get bed sores, they get UTIs, they get sepsis, they die. And sepsis is not a nice way to die. I don't know if anyway it's a nice way to die. Pelvic fractures are more common. They often involve lateral surfaces. They're more likely to bleed, and good to be aggressive with IR to stop that bleeding. And again, if they're on anticoagulants, reverse them. So management of MSK injuries, always ABCs, pain control, treatment, the least invasive but a most definitive procedure that allows early mobilization. This is my Aunt Frida. She had COPD, so on oxygen. She's in a assisted living facility in Jersey. She tripped on her oxygen line, broke her hip, and then couldn't get out of bed, got pneumonia, wound up dying. Right, soft tissue injuries, skin easily breaks and tears, more easily gets infected. You need to do good wound care. You want to avoid the cubitus. Remember tetanus immunization, good nutrition and hydration. One thing I learned, when you have these friable kind of lacerations, a nice way I like to use to repair them is a horizontal mattress, so you stay away from the friable edges. This is something that actually Mike Stein taught me. Elder abuse and neglect, it's common, so you need to consider it if the injuries don't make sense. And often it may be someone in the family or the home attendant that's doing that to the poor victim, right? So just like in little kids that get abused, older people get abused, right? Some clues, physical signs of neglect. They're dirty, no one's taking care of them, they have bad decubiti they shouldn't have. And if you're worried about it, get social service involved, report it to Adult Protective Services. Don't send them home to a dangerous environment. You got to look for it, stop it, and prevent it. So your disposition, you should have a decreased threshold for admission, right? Certainly consider admitting them if they live alone or they have no support at home and no one's going to follow up on them. If their comorbidities have exacerbated, their CHF becomes worse when you resuscitated them, right? Don't hesitate to admit them for pain or safety issues or for follow-up issues. And always think about rehab and also end-of-life issues, right? And do they have a health proxy? Do they have a living will? Do they want that? What do they want? What are their goals of treatment? So don't discharge them to an unsafe environment like this. I know some of you would probably want to send me home like this, but no way. Always make sure they have good follow-up. Get social service, care management involved, something to always think about and to ask about. Do they need help at home? And older people who fall need a comprehensive geriatric assessment to prevent fall. So make sure they have a good referral to primary care, to geriatric clinic, etc. At County, we have really a very good geriatric clinic that you can refer to. So in summary, the elderly are more susceptible to injury. They have higher mortality and morbidity for the same kind of injury as younger people. The mechanism of injury is a little different. Falls from just their usual height of standing up is enough to cause something bad. You always want to rule out a medical cause of why they fell. You want to do a good evaluation. And if you find something you can fix, then fix it. But always think about risk-benefit. Okay? Anyone know what country this is? Haiti. All right, here are my references. Any questions?